I really hadn't given much thought to this topic until I was asked to speak on it, but I'm going to clarify it as well as we've clarified carotid endarterectomy and cabbage, which 20 years ago when I was with Dr. Hertzer, it was about as clear as it is this morning. But let me just ask, has anyone here treated both carotids at the same time? Once. Dr. Katzen has a 1. Okay. So I'm not, make sure I wasn't that far out there. I was pretty surprised when I started looking into this. If you look for the incidence of severe bilateral carotid artery stenosis, and severe is defined as greater than 60%, in a series of over 23,000 patients in a 4-year period, 35% had bilateral high grade based on greater than 60% stenosis. So it isn't very common. And we all know that the Duplex criteria for carotid artery stenosis is developed at the University of Washington, are standardly used to define the degree of stenosis. However, with bilateral carotid artery stenosis or a contralateral occlusion, there's elevation in the flow velocities contralateral to a high-grade stenosis or occlusion. So I would recommend that any patient who may have bilateral carotid artery stenosis, based on ultrasound, undergo an imaging study, either CT angiogram or MRA, or as a secondary choice, a conventional arteriogram, so that you know exactly what the degree of stenosis is. So in terms of bilateral carotid artery stenosis and which side to treat, you know, the options are to treat the higher degree of stenosis, to treat the carotid to the dominant hemisphere, obviously to treat the symptomatic carotid. I haven't really found a big series of symptomatic bilateral carotid artery stenosis, so I think that's a bit of a dilemma. And then the question is whether to treat them simultaneously. I asked that question because I didn't think anyone had, but then when I looked in the literature, there have been quite a few studies of simultaneous bilateral carotid endarterectomy dating back to '69 and most recently 2000, 2001, 2005. Just to highlight a few of these studies, this was published in 2001, 6 patients who underwent bilateral carotid endarterectomies compared to 20 patients who underwent staged, one side then the other. Now, Dr. Hertzer would have a coronary if he saw me show this on the slide, but there was no shunt and there was no patch in any of these patients. They were all kept in the ICU for 24 hours, which is a little odd to me, and a 4-day hospitalization is something that I don't think we've done in quite a while. There were results for the combined group, or the, simultaneous group, Group A, and the staged group are very similar. They had 1 stroke in the bilateral group, 3 in the staged group, which is a bit high. They had 11 post-endarterectomy hypertensive patients in the open group, which I thought was, in the stage group, which I thought was a little high. They stated that there was no mortality and they had 1 TIA, the stage group, as I mentioned. Now in yet another study published in 2005, this was 18 patients who had bilateral carotid artery stenosis. The symptomatic side was treated first. Bilateral endarterectomy was performed in 2 cases. And this gets to carotid stenting versus endarterectomy and the combination of the 2. Carotid stenting was done before endarterectomy in 13 patients, and bilateral carotid artery stenting was done in 3 cases. The degree of stenosis was slightly greater in the group with endarterectomy. A mean stenosis of 65% seems a bit low. Following treatment, no remaining stenosis in the carotid endarterectomy group, approximately mean of 6% stenosis in the stent group. No complications. However, when they looked in, Dr. Katzen mentioned this, when they look at diffusion-weighted brain imaging in asymptomatic patients after the procedure. After carotid stenting, a third of the patients had asymptomatic lesions versus carotid endarterectomy where there were none. So their recommendations were to consider carotid artery stenting or endarterectomy for bilateral patients, with the caveats that they recommended against carotid stenting for patients who had a soft plaque, an eccentric lesion, a tortuous lesion, or a narrow lumen with massive plaque. I think this defines pretty much every patient that's had a carotid stent. So, but there is I did include their imaging here. So this is a patient they would consider for carotid artery stenting, and this is a patient that they would consider for carotid endarterectomy. And I'm sure most of you have treated either of these images in either way, so I'm not sure what that all means. Their conclusion was that combined therapy using carotid artery stenting and carotid endarterectomy is beneficial for patients with bilateral carotid artery stenosis. Again, this is a small series. It's a little bit light on some details, but it does, in terms of this talk, show that as late as 2005, people have actually published treatment of bilateral carotid artery stenosis. One last study from 2004, 104 consecutive patients with bilateral disease defined as greater than 60%. So following ipsilateral carotid artery stenting, they looked at the peak systolic velocity, and this gets back to why you need imaging for bilateral carotid patients. In patients with unilateral carotid artery disease, there was no change in the contralateral velocity. In patients who had bilateral carotid stenosis, the contralateral peak systolic velocity dropped. Therefore, a conclusion, which we've kind of known for a while, is to repeat the ultrasound after intervening on one carotid. And this is just graphically, so this is the contralateral carotid, and this is pre-stenting velocity, post-stenting velocity, and this is unilateral stenosis, pre-stenting or pre-treatment velocities, contralateral, no change. So their conclusion was treatment with patients with bilateral disease may be treated by staged carotid endarterectomy followed by stenting or bilateral carotid artery stenting. Once again, we have to be fairly stealth in what we recommend for these patients until there's a better volume of data for this topic. So once again, thank you for the invitation.
Thank you, sir.